it makes me so happy to see all of us gathering from all over North America to hear the great wisdom and message from Dr. Stevenson. We're going to go ahead and get started tonight. Thank you again for joining us for our third webinar series. This is really exciting. Last week, the team here at Univet had the pleasure of attending the Academy of Operative Dentistry in Chicago. Dr. Stevenson is one of the founders of the event. It was an absolute hit. Some of you were there. It was great to see it. And if you missed the event, you got to get signed up and attend next year. It was a great time. Beautiful hotel, beautiful people, and I think the courses were excellent as well. I was talking to Dr. Stevenson a little bit about what he's up to when he's not doing world-class dentistry, and he's teaching all over the country right now. He's up in San Francisco teaching a veneer course. He told me that his courses are filled up to October and September. I guess there's really no surprise for that. So when we stop for the break, head over to his website, Stevenson Dental Solutions, and get signed up for a course as soon as possible so you can come to these hands-on workshops, because they're a truly remarkable learning experience, and they just fill up really fast. So I guess, without further ado, once again, on behalf of everyone at Univet and Laris Research, our partner in Handpiece, I'm going to turn it over to the great Dr. Stevenson. Thank you.
Oh my goodness, Devin. I hear that those props, and I'm just shy by nature. It's hard for me to even speak in public, quite frankly. You may think that's ridiculous, not true, but it is.
Yeah.
Because I'm much more of a one-on-one mentor. I really get a lot of joy out of doing that. And thank you for mentioning some of our courses. Let's get right to it, because this journey in ceramic restorations is in depth, as we've mentioned. We spent a lot of time on the last two segments on preparation designs, and I think that was really important to do. Now we're going to talk more about the delivery of the posterior ceramic restorations. In part 4 and part 5, we're going to journey into the anterior world of veneers. But for this part here, we're going to focus on these topics and I'm going to get my cursor in the right place. Here we go. Impressions, immediate dent and sealing, and then cementation. And this is a case that I actually just loaded recently to show you that a gold inlay had a fractured lingual cusp, and the patient was a dentist. She's with us today, and I'm not going to mention her name, but she's attending this webinar tonight. And after the gold inlay, which was a really large one, had served her for well over 12, 13, 14, 15 years, something like that. She did fracture the lingual cusp, and that kind of thing happens. That was an inlay that I did on her. That was my bad. Probably should have onlayed that cusp. You never know, though. Sometimes things don't last forever. But it did give her, a decade and a half of service. And she came and had the lingual cusp fractured, and then she had some composite put in there just to make it so that it wasn't sharp and uncomfortable. I, of course, was very enthusiastic about remedying the situation, and didn't know what kind of restoration we were going to perform. So if you look at the upper right, I'm utilizing here a B4 clamp. The B stands for Brinker, and Hunter Brinker was his name, was a gold foil kind of dentist from the old school way of approaching things. Mostly did amalgams and gold foils and gold inlays and crowns and things. He developed these clamps because they were really good at retracting the rubber dam and the tissues to expose calculus on the roots of the teeth. So he would do scaling and root planing with a rubber dam in place. And his son, Richard Brinker, and I are good friends. In fact, I just saw him in Chicago. We spent time together talking about his dad and how he'd invented these clamps and more about that that process of developing a new innovative product to allow people to do something that they had been doing, but to do it with better clarity. And one of the things he always said was, to see is to know. To see is to know. And if we can retract the tissues adequately, we can see our margins. And so we can move on to a bonded buildup in the lower left, and then on to the preparation design, which in this case was a type of a 3/4 crown. And then we pack retraction cord with the rubber dam off finally, and then make the restoration, cement it, finish the margins, polish it, and have a decent result for a situation that was, in some respects, maybe destined to be a crown. And the thing that made this work so well, in my opinion, was two factors. Number one, the rubber dam. It was just absolutely essential to be able to get below the fracture and visualize the margin and be able to develop a fillet margin in that area. And the other thing that made it work well was this, and this is the impression. And this is something that, if I'm looking back at my own experience in dental school, I didn't have very good instruction on how to take a good impression. It was difficult for the instructors to teach in preclinical, right? So when we got to clinic and we started doing crowns, we learned on the fly. We learned in the clinic itself how to take a nice impression. And it depended on how many crowns you did. Now, when I was in dental school, I did 35 crowns or something like that. But today, a lot of the recent graduates I've spoken to haven't had that blessing of all of those experiences. They did far less than that. And I think that probably has impacted their confidence with impression taking. So I did want to talk a little bit about the importance of impressions and the technique that I utilize to get the impression, usually on the first time. Now, every once in a while, we have to retake an impression. I would say maybe, one of my friends is with me today here. She could probably say how often she needs to retake impressions, but probably less than 1 in 50, I would say, something like that, maybe a 2% failure rate. I just recently had a case with 20 veneer preps, 10 uppers and 10 lowers, and I got the lower impression in one try, and it also had some onlays mixed in with the veneers. And then the upper impression took me 2 tries, and it was only one tooth that I had a bubble on a margin. Everything else was clean, but I still retook the entire impression. So a little frustrating, but that's just dentistry, right? So let's talk about how we can work towards getting clean impressions like this on a day-to-day basis, and how that would work. Now, obviously, preparation in a way that would be atraumatic to the tissues is super important. We can protect tissues with a rubber dam. If we can't use rubber dam, sometimes it's impossible, right? We can at least pack cord before we even start the preparation. So a very small cord placed around the tooth before you prepare the tooth can sometimes be very helpful, because once things start bleeding, it becomes really frustrating, and it becomes an issue of, gosh, I need to stop the bleeding and I need to work on this. And maybe the patient is getting kind of antsy. They want to wrap things up. Their anesthetic is wearing off. They're bleeding. There's a lot of saliva. The tongue's flopping over, and it just becomes kind of a frustrating situation. So minimizing the bleeding is pretty important. One of the things we want to be really careful of, and I'm guilty of this too. I mean, look, I'm a wet gloved dentist. I see patients all the time. I deal with problems just like all of us do. I deal with post-op sensitivity issues and things that break and impressions that aren't right and lab work that isn't exactly the way I want. And I have all the same problems that everybody has. And but what I've tried to do is make those problems less frequent. And that probably has been the greatest gift of having great mentors help me, is that I've been able to learn from what they've discovered is problematic, and then implement changes so that I don't have the same experience that they had. So if I can share failures with you and maybe give you some suggestions on how we can mitigate those types of problems and challenges, that would be potentially very powerful, and you can cut down on remakes and problems. So one of the things that a lab will hear or will have to do actually is communicate with the dentist and say something like, hey, doctor, your impression was contaminated. And so when you look at this impression, and this is a real impression that was taken by a dentist that was submitted to my laboratory. I have a big motorcycle outside apparently. And you know, this is what the impression looked like right here. And you can see is there's significant contamination at the margins. And then what does the dentist sometimes say to the laboratory when they have something like this? Well, what they say is, it was a really tough impression. It's a tough case. Please work with it. Please make it happen, because I just can't imagine bringing the patient back and having to go through the whole impression again. That means I got to get them numb again. I'm going to have to explain why it didn't work. And it's a money loser, right? I mean, we all suffer this trauma from time to time, but we want to try to minimize that. This is the kind of impression that we also see. And I owned a dental laboratory for about 6 years. And we had really good dentists that submitted their cases to us that would occasionally submit a case like this. And this is what we had to deal with. And I can tell you that this impression would be a failure in terms of trying to get a good fitting restoration. And really the problem in this case was that there was phase separation between the light body and the heavy body. And then most likely that the reason why that happened is because the dentist did not cover the entire tooth with the syringe material. And so sometimes what happens is while you're injecting the syringe material around the preparation, you focus on the marginal area and then you let the occlusal part not get covered necessarily. And so my recommendation would be flood the tooth surface. Flood the tooth surface, simply meaning cover every square millimeter of tooth structure as though your life depended on it every time. And then you'll have much fewer incidents of this type of problem. Here's another case that was submitted to our dental laboratory for a final zirconia crown. And you can see that there's pretty poor capture of the margin on that upper right area. And the problem with this case was the impression is underextended. It did not extend into the sulcus area, did not capture the finish line adequately, nor did it capture a minimum of 0.5 millimeter beyond the margin. I'd like to see even more closer to 1 millimeter beyond the margin when possible. So it's not always possible, but at least 0.5 millimeter would be good. And the problem here had nothing to do with moisture contamination. The problem in this particular situation was the failure to retract the tissue adequately. So in the first case, it was the tooth was not covered completely. In the second case here, the tissue was not adequately retracted. And I'm going to show you what I use. It's a 2-chord technique. And we use a small first chord and a larger second chord in this 2-chord technique. Here's an example of a margin that is shiny. And when you look at impression material and it doesn't have a matte finish, but it actually has more of a shiny finish, this is an indication that the impression material was taking an impression of moisture. So if you were to take impression material and just lay it on top of a wet countertop and let it set, it would have this shiny surface. If the countertop was dry and you put the impression material on the surface, it would have a matte finish. So we've always kind of looked at these situations and kind of blown them off, but actually they're pretty serious because all you're capturing here on that distal is an impression of the moisture. And that's exactly what happened here. So the problem was moisture contamination and failed to dry the sulcus after the cord was removed. And the solution is dry thoroughly. And I want to talk to you about my technique to mitigate all of these problems I've just described, because these are the three major reasons why impressions are rejected: is a problem with drying, a problem with coverage, or a problem with retraction. So let's go over a little bit of how we might approach that. One of choice is electrosurgery, and I've been using electrosurgery since I was in dental school. I have my own electrosurgery unit. I have always had one in practice, and I think that it's probably good to have as a backup. And I would say that it's used when the tissue is draping over the finish line. Even when you pack cord, sometimes the tissue will flop over in on top of the finish line, and that's a difficult situation to be in. So when the tissue, doesn't allow you to get access to your finish line capture with the impression material, electrosurgery is pretty good. It's quick, it's safe. The disadvantage is it does affect the tissue, and there is a little bit of postoperative, healing that has to go on. It's a little more aggressive than other techniques, but it is really great to have when you have tissue that covers over the margin. The other technique, of course, would be a laser, and there's lots of really good lasers out there. This little one here, this little Picasso is a nice one. I've been using this one for many years. It works great. And it's the same reason you would use the laser as you would use the electrosurge. So it's kind of a matter of what you feel comfortable with. With electrosurgery, you have to ground the electrosurgery on the patient's body with a little grounding plate, and you have to remember never to have metal next to the electrosurge unit, otherwise you can shock yourself or the cheek of the patient. With the laser, the only disadvantage really is it's a little slow, and you have to also have eye protection because of the laser light being very dangerous. So those are two pretty good techniques to have around, and I would consider these to be secondary techniques, not primary techniques. For me, the primary technique continues to be retraction cord. And I know a lot of people groan and moan when they hear me say this, because they're like, "Oh my gosh, really? Isn't there another way? I mean, these cords are such a pain, and their patients feel uncomfortable. It takes forever to pack cord. It's a pain." In those 20 veneers I packed 20 cords around those teeth. And I can tell you that it's just sort of a labor of love. And once you place all the cords, you get to see your margins really clearly. And sometimes you'll need to go back and do some refinement that you weren't able to see, maybe even with the rubber dam on. So I think it's for me, I think this is my number one go-to technique. Excellent control of bleeding and tissue if 2 cords are used. If you're using a 1-cord technique and you're packing the cord and you're pulling that cord out, there's very little that's going to keep that sulcus from collapsing back on top of the finish line. Also, there's nothing really inside the sulcus as a barrier to keep the blood from oozing back up and getting in the way of the margin. So, but let me go over how we do this, because I think it can be really helpful to understand the 2-cord technique. I learned this technique from a prosthodontist, and he taught me this technique in 1984 when I was a dental student, and I was a new 3rd-year student. And he said, "Let me teach you the 2-cord technique. It'll change your life." And up to that point, having done a few crowns already, I was ready to hear anything, because, man, I mean, it seemed like it was nearly impossible to get a perfect impression on the first try. And what he showed me was this technique where you could place a very small cord, something that was really, really gentle and had a minimal diameter, place that around the tooth, cut the cord so that it was even, and then place a larger cord on top of it. And the larger cord could be a 1, a 2, or even a size 3 cord. There are times when I'll use a 3-cord, and I'll even bring the 3-cord around twice, because I have really boggy tissue, particularly around lower second molars on the distal. You can run into situations like that. And I was talking to one of my colleagues, Dr. Tina Lopez, who's an incredible dentist, and she is kind of the go-to faculty member at UCLA when it comes to impressions that don't work. She'll show faculty how to take a proper impression, and I can tell you that it takes a real attention to detail, and a little bit of what's the word I'm looking for? Resiliency, stick-to-itness, so you don't give up. And you have this methodical approach where one cord is placed very, very carefully, and the second cord then is put on top to displace the tissue. Now, these cords I have in the upper right here are called Unibraid, and they're made by Van R. Now, Van R just sold the company to Kerr about 4 or 5 years ago, and but they're available in these Unidose little delivery system. It's pretty cool. These are epinephrine impregnated, and I would not recommend these. I think that we should just stay away from epinephrine impregnated cords, because the amount of epinephrine in that is more than you would have in an entire cartridge of anesthetic. Sometimes it's a factor of 10 times as much epinephrine in 1 inch of cord compared to you can imagine 10 cartridges of anesthetic with epinephrine would have to be would be equal to 1 inch of this cord. And so I'd stay away from the epinephrine cords. Instead, what I do is I use an alum cord, and the alum cord is aluminum potassium sulfate. And then I combine that with aluminum chloride 25%. I don't like using the ferric sulfate and ferric chloride. And the reason, they're very potent, they're very, very, very potent anticoagulating agents, that's for sure. The problem, or coagulating agents, excuse me. The problem is the coagulated tissue is very difficult to remove from the sulcus, and it can get into all the little scratches along the margins or in the sides of the tooth where you have diamond scratches. It accumulates there, and we look at these preparations underneath the microscope after you pour them up with the ferric sulfate or ferric chloride being used. You see a lot of contamination on the surface, on the margins, etc. The manufacturers say that it's clean, there's no issues, but I disagree completely with that, because you need to take a look at these under high magnification. So I don't recommend them. Do I have a bottle of this around in emergencies? Yes, I do. I can tell you that I use probably 1 drop of it every 5 years for some really, really difficult impression. The overwhelming majority of the time is just aluminum chloride 25%. And you can even have a pharmacist make this for you. A compounding pharmacist can put 25% aluminum chloride in a buffered saline solution of 75% water saline solution, and they can make this for you very, very readily rather than having to buy it from the manufacturer. You can save a ton of money. The other thing I like doing on top of the cords is using a tissue pressure cap. These are just phenomenal. I could not practice dentistry today without them. I will say that without any hesitation, that they're an absolute must in your impression world. And basically, different companies make these. And what they do is they sit on top of the tooth and they put pressure on the tissue, and they soak up all the tissue curvicular fluid that may make it past the cords. So they're really, really helpful for this. And so I just have the patients bite down on this, and after 5 minutes, you pull the little cap off, their Compri cap off, Compri cap. They made by Royco and Premier, the 2 companies that I think make those. But when you pull it off, you usually see something like this. And this is the top cord still in place. It's the number 2 cord. And then once we remove this number 2 cord, the sequence is as follows. Put the first cord down, cut it so that it's even, put the second cord on top, which is larger, either a size 1, size 2, or size 3, depending on how much pressure you need to exert on the walls of the tissue. And then put the Compri cap, have the patient bite down for 5 minutes, and that's it. And they just rest their jaw. And they're putting pressure on the tissue, and they're soaking up all the moisture, etc. And then when you're ready to take the impression, you pull this off, and you're going to find something kind of like this. I mean, it gave me adequate time even to pick up my camera and take a photograph. And you can see that it's just very clear where things are located, and there's no bleeding. And then I'm going to rinse. and this is pretty important. If you don't rinse right now and you just grab hold of that cord and start pulling it out, the problem is it'll start to rip the sides of the tissue in like a wound, almost like pulling a bandage off of a wound and causing it to bleed again. So by getting it wet, it loosens it up and allows you to pull the cord out without trauma to that sulcular area. Then once it's pulled out, we do some rinsing of the area. So we rinse out any medicaments that are in the sulcus, any debris, rinse what may be left over, residual little coagulated pieces of blood or whatever might be hanging around, but you're leaving the zero cord in place, okay? And the zero cord sometimes needs to be pushed down a little bit because sometimes the zero cord comes up a little bit towards the finish line when you're pulling the top cord. And then you can just re-push it down a little bit. And now, while my assistant is loading the impression tray or getting the scanner ready, right? So we can either scan this or we can take a conventional impression. I still do the same tissue management, whether I'm taking a normal impression with, let's say, traditional impression with polyvinyl or polyether or something, and versus scanning. It's the same exact tissue management sequence. There's nothing different. You know, sometimes people get scanners and they think, oh, the scanner is going to be great. I won't have to worry about taking impressions. And really, the hard part of impression taking isn't putting the goo in the mouth. The hard part is all the stuff that leads up to that moment, right? So what the biggest disillusionment people have with scanning is that they still have the same issues they had with conventional impressions, and sometimes even worse problems, because at least conventional impressions have a physical attachment to the finish line, and that you're able to grab it when the starting to collapse, rather than taking a passive swipe with a scanner. And I've been scanning since 1987, and I have had numerous scanners in my office over the years. I have 2 scanners right now. I have an iTero and I have a PrimeScan, Cyrix PrimeScan. I just had a Trios that I had before that, and it all needs to be done in the presence of ideal, optimal, dry sulcus areas. So we can then, with a dry sulcus, while the assistant is mixing, I'm just blowing airstream over the tooth. She's mixing, hands me the syringe, I inject, and then load the tray in the mouth. And this works incredibly well. Sometimes for inlays and onlays, you can't use a compra cap, you know, that cap that fits over the crown prep. You can't use that on an onlay. It doesn't work, because the part of the onlay or the inlay that you have to get isolated is the area that's in between the teeth, right? And so that compra cap needs to fit on top of a cone-shaped preparation. So what I do instead for inlays and onlays is I use a little bit of this, these little pellets made by Pascal, and they're basically little cotton pellets. They're sometimes they come with epinephrine. You can also get the ones without epinephrine, and just put one pellet in the interproximal area where the box is, and that sort of works like the compra cap. It's sort of my version of a compra cap. If you don't want to use these pellets that are pre-made like this, you can just take a cotton pellet, put a little bit of aluminum chloride on it, squeeze out the excess, and then stick that in the interproximal area. I like these little cheap, little single-use syringes. We use these all the time. One company that makes them is called Ho, and they're called Better, Faster, Cheaper syringes. And you load them from the back and then fill them up about maybe 3/4 of the way, and then you insert the plungers in the back side of it. And another company that makes these is Zest. They're all around now, and I really dig these because these little guys are really conservative of the amount of material you would normally express if you just were to put that mixing tip on the end of the syringe, that barrel. The amount of waste you have in that little barrel is more than the waste alone is more than what you would use to take the entire impression with the these little BFC syringes. And there's zero waste with these. Well, it's just incremental, minimal little waste in the tips, because the tips are very small. I like these because you can handle them like a syringe rather than a gun where you're grabbing hold of this bulky sucker and you're 9 inches away from the preparation as you're trying to get the tip in the right area, I think it's a big mistake to use those little tips that screw onto the end of the syringes and use the gun to deliver it. I think it's a big no-no. And I've never had anyone in my study clubs go back to those once they learn this technique. This technique is far superior. And we want to flood the tooth. So if you had a couple of preparations, and you're trying to go around the preparations, I'm just showing this on this is a couple of preps a student did, and I'm just showing this with the way I would dispense the material. I push the tip of the syringe directly on the soft tissue. I can feel the resistance of the syringe as it's contacting the tooth margin tissue interface. And I'm not letting it drip down. I'm pushing with force into the sulcular area as we go around the tooth. I see people do impressions and the tip of their syringe is 2 or 3 millimeters above the finish line. And they're just hoping that the material just sort of passively finds that interface. Not a very predictable technique by any means. So we really push hard to get this material all the way down into the sulcular area, like we're showing here. Now, at this point, a lot of people would say, oh, wow, that's pretty cool. I'm done. Now I can just load my tray. But my recommendation is that you continue with the injection material all the way up to the very top and then cover the surface. Every square millimeter of that prep is covered in your syringe material. And if your syringe material is monophase, that's great. You're going to have, you can do it that way. I'm using here is occlusal XLV, which means extra light viscosity. Panasil makes an incredible extra light viscosity made by Kettenbach. Every company has some form of a low viscosity material that can be syringed very nicely around the preparations. And I love this product. And then we're able to take impressions that meet the criteria of getting at least 0.5 millimeter beyond the finish line with no contamination. A nice clean preparation can be captured this way with impression material, rather than having a beautiful prep and then you never really transfer that beautiful prep to the laboratory because of an error in your impression technique. So details can be captured quite nicely. Let me show you, I'll take you through this with an example of removing a crown. And I wanted to just show you that how we deal with impression in a case where there's some inflammation around the crown. And so the crown needed to be removed because of issues with the fit, and the rubber dam was placed, inverted, and then cord can even be packed at this point for the crown removal. I always use rubber dam when removing old restorations, even crowns and even bridges. It's just a wonderful insurance policy to prevent problems like aspiration of particles or swallowing the particles. And it just creates a much safer environment to do this. People are shocked when they hear that I do this. They're like, you got to be kidding me. You actually place rubber dam for crown preps? What? Are you okay in the head there, buddy? And the answer is, of course I am, because I don't want to hassle with all the problems that come when you start disassembling a porcelain fused to metal restoration. So the first thing I do when I'm taking off a PFM is I use a coarse diamond, and the coarse diamond is used to get down to the metal. And when we remove feldspathic or Emax or zirconia monolithic, I'll show you the technique is a little bit different. But basically in the PFM world, I remove the feldspathic with the coarse diamond, get down to the metal. And once the metal's exposed, now I switch to a carbide. And the reason why I like carbides, and specifically the 330, is because the 330 burr is 1.6 millimeters long. And so I can use the burr as a guide for how much reduction I'm going to need in the final preparation. It's a it's a fiduciary depth cut. So while you're disassembling, you're thinking ahead, because if I cut this crown off and I only focus on just getting past the cement, getting to the cement and then breaking the crown off, I don't know, relatively speaking, how much reduction I have relative to what I want. So by using this 1.6 millimeter burr and scooping down through, cutting down through the metal, then I can create this guide, and then I know exactly how much tooth structure to remove once I remove the entire crown. It's a super cool little trick that you can do when you're taking off old restorations, because it provides you with here's the plan. We've just cut through the metal at 1.6. We want to have a 1.6 to 2 millimeter reduction. I can use that depth gauge that I just created there as a great guide. I do like to leave a little bit of metal on both lingual and buccal. So I don't want to cut all the way through the tooth, all the way from one side to the other, because what happens then is one side will come off and the other side will stay on the tooth. And now I have to contend with removing that piece. But by leaving them connected on the buccal and lingual, or at least on one side, you can now use a tooth crown spreader type instrument like this. This one happens to be made by Brasseler. There are a lot of them out there. I don't like using T-bars, those really aggressive things that almost look like, they almost kind of look like an oral surgery instrument with this little T attached to it, and you grab it like you're going to grab a tool in your garage or something, and you really can twist it. We've seen major problems with that, and I outlawed them at UCLA when I was chairman of restorative, because they were very, very hang on a second, let me cancel it. Okay. They're very aggressive, and we've had students engage them into the groove that you just created rather than engaging the crown, and twist so hard that they were actually able to break the tooth in half. So I would use a gentle twist action with the crown spreader. And now we've disassembled this old PFM, and look at the PFM, and it had these 4 grooves in it on all 4 sides, and they were already there, right? But I want you to take a look at a couple of things. Take a look at that groove that I placed on the occlusal. You might have thought, whoa, I never would have reduced that much. I would not have thought that's how much it needed. I would have assumed that there was enough clearance because there was already a crown there. But we cannot make that assumption. We need to look at every situation like it's starting from scratch. And so this groove now has become a guide for letting me know how much to remove those cusps. It's fantastic. And then the other thing I want you to notice is, look at the rubber dam, how the rubber dam is inverted into the sulcus area. So we can continue to prep this tooth with the rubber dam on. Once the preparation is completed, and we're going for a pretty robust, thick axial wall here. You can refine the grooves a little bit, remove the occlusal groove area that we showed you in the previous image right there, clean things up, and now we're ready to place our cords. I don't mind using hand instrumentation to refine margins. This is a great way to remove J-shaped margins. A lot of people will use an end cutting diamond or an end cutting carbide on slow speed to try to remove any J-shaped margins. I have used hand instruments for this for my entire career, and have found them to work incredibly well with a lot of control. You can really feel the margin when you do this. And of course, microscopes help. I use a microscope. This is in my previous office where I was kind of renting a room from one of my colleagues. Now I have a much bigger room and a different microscope, but microscope dentistry comes in handy for these types of things when you're at the moment where you're trying to refine something. And then my dental assistant was going to grab hold of the 0 cord, and we don't use, and I know I'm going to make a few people kind of frown with this, but I do not advocate the use of knitted cords. A cord that is knitted is kind of like a sweater if you can imagine like a knitted sweater, and it's a sleeve of the sweater. If you were to just take it from the shoulder to the cuff, that's a knitted cord. The theory is knitted cords fill up in the middle with medicament and they expand. The reality is that's the opposite of what they do. Knitted cords collapse under pressure. One of the reasons why people love knitted cords, because they're very easy to place in the sulcus. But they're easy to place, but they don't give you any of the necessary retraction that you would get from a solid braided cord. Huge recommendation. It's a very disappointing one for some of you. I'm absolutely certain some of you are just rolling your eyes going, oh my gosh, I've been using knitted cords my whole life and there's no problem. Well, I disagree. I can, if I took my top students and just said, place a knitted cord versus placing a solid braided cord like this, you will be able to see the difference in the impression every single time. You will always get better impressions with these solid cords. I call them solid cords because they're not hollow in the middle. So my huge recommendation at this point is to never use the knitted cords when you really have an impression that matters. This is the technique that I was taught by the prosthodontist almost 30 years ago. And I haven't altered from it, but I have certainly tried other techniques and have seen impressions with the other techniques. So when we pack the cord, and this is kind of cool, you want to pack backwards. And so as you're moving along, you want to kind of think about this like you're planting an oar in the water and you're pulling it back, like you're rowing in a boat. You pull it back. So we do this backpacking technique. And what this does is it keeps the cord from coming up on the other side. You know how you go around the tooth and sometimes when you're packing, it pulls out from where you just were packing like a minute before. So you got the interproximal all packed and then you start packing in the lingual and then the interproximal pops out and you're like, oh gosh, I got to pop that back in. And it's really frustrating. But by packing back like this, you're not putting any tension on the cord that you just placed. You're actually reinforcing it and you're pulling the cord against where it was. So it's packing back and we go around the tooth like this. But then there's a second step to this, and that is, so that's the 30-degree angle. The second part is you want to turn the instrument at an angle about 45 degrees, and this is called packing in. So I packing back and I packing in. So I always think about, I want to angle this in such a way as much as I can, it's not always possible, as much as I can to try to aim towards the center of the pulp chamber. So imagine in the middle of the root, as it rises up and starts to form into the pulp chamber, right in that area, in the exact center of the inside of the crown, that's where I'm trying to aim for. And so I angle it like this. And what that does, that allows the cord to slide along the side of the tooth rather than being smashed down into the sulcus and being pushed away from the tooth, and then sometimes not being able to stop any bleeding, or sometimes being pushed away from the tooth, that there'd be a little gap in there sometimes where you'll get some oozing and bleeding coming through. So once again, packing back and packing in are huge benefits when it comes to cord packing. Now, whatever you want to pack with is fine, whether it's serrated or rounded. Some people use the interproximal carver. They use all different types of things. I think you can use I don't care what my assistant hands me. I've got about 6 different types of packers, and she hands me one. I don't say, no, I can't use that. I just grab it and start using it because they're all pretty much going to work quite well. One of the things you want to do is, once you place the zero cord, you're gonna have an excess amount of cord, and you want to make it so that it butts up against the starting point. You don't want to have double layers of this cord, because it kind of defeats the whole purpose of the 2-cord technique. You want this first cord to be just hugging around the tooth nicely. The second cord you can leave a tail on, but the first cord you want to have it so that it's just around the tooth nice and evenly. Only one cord, even thickness, same thing all the way around the tooth. And to cut off that little tail, I like using these Castro Viejo scissors. And these are developed by an ophthalmologist who developed corneal transplant surgery when he was about old. It wasn't even picked up in medicine until about 10 years later. He was a Renaissance doctor. He was way ahead of his time. Thank you, Dr. Castroviejo, for the invention of all of your instruments, of which we use in medicine and dentistry quite a lot. And so these work great because you can snip off that little bit of cord without any hassle. The problem is, if you go to buy these, if you're not careful, you're going to spend a lot of money. Look at this one, $423. I'm like, no, we can do better than that. Here's $68. No, I want to do better than that. Here's Ultradent, $42. Oh, wait a second. Look at this one on Amazon, $11.99. Do you know what? It's worse. Maybe they only last for 10 times and you got to throw them out, but for $11, what a deal. I mean, so the price range on these is enormous. So I don't think you need to spend more than about $50 on a good pair of Castroviejos. And I buy them, and once they get dull, we recycle, throw them out, whatever. But they're really handy to clip off that little bit of extra cord without having to go snip, snip, snip 10 times to break off that piece. So this is the product I use, gingerbraid size 0, as my initial cord for going around the tooth all the way around. Remembering that this is an aluminum potassium sulfate, perfectly safe. There'll be no systemic alterations. You're not going to increase heart rate or cardiac output or anything like that. There's no worries. And then you're going to dip this in aluminum chloride 25% solution, which is going to be super, super safe. And once again, has no cardiac implications whatsoever. And then on top of it, because this one was a little bit boggy, the tissue was a little bit unhappy, I went ahead, and there was room for it, I went ahead and placed a size 2 cord, size 2. And the size 2 cord was a little bit more difficult to place. There was a little bit more expansion of the sulcus all the way around, but it worked really nicely. And then I leave a tail on this one. This one I don't have to cut with the Castroviejos because I actually want to remove this one before I take the impression. So remember that the steps, and one more thing, if you want another added bonus for tissue control, you can have your astringent retraction paste available for you. This one's a 3M product. They're made by a lot of different companies, and these products are really helpful for drying up the sulcus and creating a very clean and dry environment before you take the impression. So we can place this on top of the cord. And if you fear that you might have a lot of moisture and seepage coming through, you can place this on top and then put the ComproCap on top of that. So here the patient is just biting down on this ComproCap before we're ready to take the final impression. So now at this point, I remove the ComproCap. I'm sorry about the sirens. It looks like San Francisco is having some trouble right now. So sorry about that, but the cords are wetted after you rinse off all that astringent material, and then you want to remove the number 2 cord, which is the top cord, and then rinse again. Remember, you gotta rinse it again to rinse out any medicaments in there, any blood. Then you're going to dry the area thoroughly, and I'm going around the tooth, and I'm blowing the air, blowing the air, blowing the air, going around and around and around, and then we're going to be ready to repack the 0 cord if it comes up a little bit. So you got to have your cord packer ready right there. So I'm always got my cord packer right by my side in the event that I need to push down the 0 cord, get it back down where it is. But it's amazing, if you keep it dry, you have doubled or tripled the amount of time that you have to scan. You can either take the impression now with conventional methods, or you can scan, and by having it dry, if it took you a minute to scan, it would be no issue. There would be no problems at all with the sulcus leaking. Okay. Then of course, flood the tooth. And we should be able to get a nice impression every single time. I knew this was going to be a difficult impression, and that's one of the reasons why I used the number 2 chord instead of number 1 chord. If it was really bad, I would even use a number 3 chord on top of the 0. Sometimes I even use a 1 chord in my initial chord followed by a 2 or a 3. It depends entirely on the situation you're dealing with and how deep the sulcus is and how floppy the tissue is, and also how much propensity there is for bleeding to occur. And you just have to kind of get used to the feel. One of my colleagues says, if you're placing the cord and you don't feel that you're getting lateral retraction, if you're not displacing the tissue, then your cord is too small. And I think that that's a good piece of advice. You need to feel like the cord has to be pushed in, like you're overpacking a suitcase. It needs to have that feel. And that means sometimes you need to get up to a larger cord. Yes, we want to have everybody healthy, right? You want to have everyone with really healthy tissue, and everyone's perfectly clean and they floss their teeth every day. And yeah, right. I mean, this is the real world. I mean, we're dealing with patients that tell you they floss and they haven't flossed once in a year, and so we deal with this kind of problem and we have to be ready for it. So at this point, everything looks super clean, disinfect it, and then I bag it, tag it, and send it. And that goes off the laboratory. Or if it's a scan, we just send it digitally to our lab. Or if it's a scan, we can do in-house design and milling as well. So we have lots of options today in the digital world that we're in. And it's a very routine procedure. When I was preparing this case to take the impression, I had zero doubt in my mind that we would have a problem getting the impression when I followed all of those steps. Zero concern whatsoever. You may think, oh, this is not so much of a problem. In my practice, I don't have problems. But many surveys have been done of laboratories. And when laboratories respond, they mention that only 15 or 20% of the impressions they get are actually considered to be optimal impressions. Only 15 to 20%. 80% of us dentists are not sending labs appropriately captured finish lines and emergence profiles. And it is an issue that is kind of dentistry's dirty little secret. And I think that we just need to face the fact that we have been poorly taught how to do this in the dental school situation, unless you ran into a prosthodontist that teaches you something like the 2 chord technique. Or maybe you work with someone like Dr. Lopez at UCLA, and she shows you how to use the technique. So let me, there we go. And so that was my pitch on impression taking. And we're going to take a short break right now. Let's take about 5 minutes. And Devin, you can kind of take the helm. And then when we come back from the break around 7:01 p.m. Pacific time, in about 5 minutes, we'll do some quick Q&A, and then we'll get into cementation, bonding, and cements in this chapter of the ceramic series.
Sounds good. We got a couple of questions. Do you want to get this comment bar out of the way? It says, when the inner cord gets stuck to the impression, do you take it out, or do you let the lab tech take it out?
Usually, I'll take it out because I do a lot of my own lab work. But I would recommend that you just let it stay in there. Some labs will just spray the impression with a little bit of surfactant, and that'll soak into the cord a little bit. And then they'll pour it with stone, and they'll let the cord stay in the model. And then they'll trim the die, and then the cord will come out at that point, rather than tearing it out before you pour it up. My recommendation, if you tear it out before you pour it up, then the cord will not be a source of soaking up the moisture of the wet stone, which could alter the water powder ratio. So the way to mitigate that is don't remove the cord, let it sit in there, but spray it with a little mist of surfactant before you pour up the cast, pour up the impression with your stone, and then you've kind of neutralized what could happen to the water powder ratio by just having it just slightly moist. And that's typically what I do.
Interesting. Okay. Second, rather another question here. Do you take one-step impressions or two steps separating heavy and light body? I personally use cellophane over the heavy body for creating
Yeah,
a space
understand.
for light
Yeah.
body.
Yeah, I understand that. That's a great technique. Basically, it's a heavy body or a putty wash technique. Putty wash techniques work super, particularly for full mouth rehabilitation cases, because you get a lot of pressure exerted from putty or the heavy body on top of, and that helps to push the material in, kind of hydrodynamically pushing it into the area. The only issues with those is sometimes you would wish to have a little bit more space, and the thickness of the wash material is so thin that when you pour up the dyes and you're separating the stone from the impression, it's very tricky without breaking the dyes, particularly if you have thin preparations. The cool thing about a heavy body, light body one-step technique is that there's a lot more flexibility in the impression. So when you pull out the stone, you're not breaking off the stone. And this is a huge laboratory reality. It's not, see, we get all excited. Oh, we took a beautiful impression. The lab can handle this, no problem. But yeah, most of the time they can. But if that area of the light body is very thin up against that putty, it can be a little tricky sometimes for the lab to pull the stone out of the impression. That's all. But otherwise, it's a phenomenal technique, and I've used it many times. It's not my routine though.
Gotcha. Dr. Stevenson, can you please mention what is a different technique you use to remove Emacs and feldspathic crowns?
Yeah, coming.
Oh, okay. They're one step ahead, Dr. Stevenson. Last
Awesome.
question. Favorite loops, Dr. Stevenson? Just curious.
Yeah, I don't know if I'm willing to say in mixed company, but no, I will. Honestly, I work with about 3 or 4 different kinds of loops. One is Zeiss because that's my microscope. One of them is Designs for Vision because I have a 6 power Designs for Vision, and Univet doesn't make a 6 or 7 power loop yet. So I've been kind of harping on them to develop I think a 7 power loop would be amazing. You could call it the 007 series. You guys could have a lot of fun with it, but we don't have the 7 power loop from Univet. So my magnification on my Univets is a little bit lower than my 6 power mags that I get from Designs for Vision. But in terms of the clarity and the optics, the Univet are equal to Zeiss. They're just amazing. And then I have a pair of oroscoptic, the ones that you can rotate from 3 up to 5. I'll sometimes use those when I'm teaching because I'm constantly wanting to change from lower magnification to higher magnification. And they kind of work great when you're at the teaching desk and I'm doing different things. But I think that's the honest answer. I love the optics and the style of the Univet. I love the quality. I love their light. I just wish they had one step more magnification. And for me, that's important. For most dentists, 3.5 and 4 and 4.5 and 5 is absolutely maximum already, and they don't need more. But because I've been spoiled with my microscope, that's sort of my, it's kind of ruined me. But but if Univet comes out with a 7 power loop, I will talk that loop up till I drop. I'm hoping that Devin, you'll have some influence to your people in Italy and see what they can do, because I think dentists would love it. And it's certainly in my niche of crazy dentists that like microscopes.
We should call it the RS7, in my opinion.
You go, buddy. There you go. Okay, can we get started?
Yeah.
Okay, great. All right, let me turn off my face here and then get back on the slide. And let's talk a little bit about, this whole thing about immediate dent and sealing, and the question is, when you're going from preparations to delivered Emacs restorations, should we bond the tooth the day it is prepped? In other words, is that going to be an important thing to consider? And that's basically the immediate dent and sealing approach. And I'll tell you that there are 4 different ways to deal with this. You can do immediate dent and sealing before the impression. You can do immediate dent and sealing after the impression, but both of those are done at the preparation stage. Or you can do delayed dent and sealing, which would be done just before you cement the crown. Or you can do it simultaneously with the cementation of the crown. And I think that probably number 1 or number 4 would be the only real predictable ideal situations to be in. I would definitely push you in one of those directions. If you're doing CAD/CAM 1-day dentistry, I don't think there's a really good reason to do immediate dent and sealing, because you can just do simultaneous dent and sealing at the time of delivery, because it's only going to be about an hour after you're done milling, or even less time if you're milling some of the products that don't require any crystallization or sintering. But if your patient is going to leave your office, I would highly recommend that you do it at the preparation, and you follow this particular approach of doing it before the impression. Okay. When you look at these 4 different techniques, immediate dent and sealing, or delayed dent and sealing, or pre-cementation sealing, or simultaneous sealing, those are the four that you see here. The DDS is really after you do immediate dent and sealing after the impression. There are advantages and disadvantages to every single one of these techniques. Probably the immediate dent and sealing would be considered to be perhaps the most potentially technique sensitive technique. But in terms of post-op sensitivity, it's amazing. The risk of contaminating the seal is very, very low. And we get the highest bond strength. So I think that there's a lot of really good evidence to support doing immediate dent and sealing. And it's been around for 20 years. This is not a new concept by any means. The bond strengths we're getting are up to 5 times higher than the bond strengths you would get to dentin if you did delayed sealing techniques, or doing it after the patient's worn a temporary and then comes back. Because remember that this dentin is porous, it's vulnerable, it can be infiltrated with a lot of bacteria, and the idea is that we seal the dentin when it's freshly cut, and we can then preserve a more robust hybrid layer, a hybridization with the dentin with our bonding resins. You got to etch everything. Some people have tried to use immediate dent and sealing with self-etching resins, and that's okay. I think it's fine, but it's not going to be the highest bond strengths. If you really want the maximum bond strengths out of IDS, you're going to want to do total etch technique before the impression. And then you're going to want to keep in mind that you're going to need to do some things to the preparation before you take the impression, and I'll go over that with you momentarily. And then when we go to deliver the restoration, whether it be a week, 2 weeks, 3 weeks, whatever it is later, we're going to also have to think about how are we going to reactivate the bond? How are we then going to bond to the bond? And that's going to require a little bit of work as well. And I'll give you all the steps that I use that Manya and I completely agree on the protocol. And I have not altered my technique from Manya's technique at all. And I think that I'm very much a purist when it comes to the IDS process. There's plenty of research. Unfortunately, most of the research is not clinical. Most of it is laboratory research, but we're getting some research that's showing really great results from immediate dent and sealing in the clinical area. We just don't have a lot of really good studies that have looked at this. Doing long-term clinical trials is very, very difficult to do. It takes a significant effort on the part of the university and getting patients to come back to the university and have things evaluated. So it is one of those things that is not easy to do. But when you look at the laboratory studies, it's convincing that the IDS group, you can see there in red, a huge advantage over the delayed dentin sealing group in terms of these microtensile strength studies. When you look at the modes of failure, that what's happening in the immediate dentin sealing group, it's sort of happening at the half of it's in dentin, half of it's at the bond. In other words, being ripped apart versus being pulled off of the dentin. So you look at the delayed dentin sealing group, what's happening there is that 98% of the time the failure is occurring at the interface between what you thought was your hybrid layer and your cement, versus the IDS group. The cement and the hybrid layer and the dentin are all fusing together into one cohesive, incredibly strong structure that has to be torn apart from itself for it to fail. And that's why I think we're seeing such amazingly high bond strengths with this particular approach. Like I said, I am following the technique as it was originally designed with OptiBond FL, which is a 4th generation adhesive system that comes in 2 bottles, a primer and an adhesive. Is it possible to do immediate dentin sealing with an 8th generation or one of the universal adhesives? The answer is absolutely. There is no problem with that at all, but you have to modify your technique slightly, because what you have to remember, what we're doing here with the OptiBond FL, the FL doesn't stand for fluoride, okay? It stands for filled. Okay, which means that there's a significant amount of the borosilicate glass quartz particles in this adhesive that make it robust and really, really strong hybridization. It's a much more intact interface with this particular product. If you're using one of the more recent products, like let's say Scotch Bond Universal or All Bond Universal, any of the universal agents out there, they're not highly filled at all. And so what happens is that hybrid layer, it may look really good on the microscope, but until cement is on top of it, it's not at its maximum strength, okay? So when we do the IDS technique and you're using an 8th generation, or you could call them universals, you're gonna want to utilize a small layer of flowable composite on top of those to connect to the bonding agent and light cure that, and that creates a nice hard shell to protect the hybrid layer. And these are just examples of interesting preparation designs that have various different shapes and what have you, with blockouts, and then top of the blockout, the IDS has been performed. So let's take you through an IDS case from start to finish, so we can see how this is applied in the clinical situation. A patient, another dentist, that had a desire to replace an old restoration that was failing on the first molar. You can see that it's had some ditching of the margins, and the contours are not optimal. It was starting to leak and discolor, and so she wanted to have this replaced. You could also see how the remaining lingual cusps are compromised. There's not a lot of tooth structure that looks really stable over there. You can see the wear facets, the erosion occurring on the distal lingual cusp. So the decision was to, unless the tooth was very broken down and defective, that we would go with an MOD onlay covering the lingual cusp and the buccal cusp with the technique that we've discussed in the prior sessions. So as we always do, is we attempt the rubber dam. And I don't want to say we always place the rubber dam. I'm going to say we always attempt the rubber dam, because sometimes rubber dam cannot work, and you try it and you're like, nope, it's not working for me. I need to take it off and just do this without the rubber dam. But we always attempt to try to get a rubber dam on and then get it inverted properly so that we have a good seal and we don't have any issues with moisture contamination. You kind of turn the patient into a type it on when you do this. It's a lot easier to work in this world than it is in the world where you have a tongue and cheek and saliva getting in the way. As I showed you before the break, when I disassemble an old restoration, I'm always thinking about how can I create some information that I can use to finish the preparation. And in this case, I knew I was going to be using Emax, okay? And this restoration that she has in her mouth is a class 2 ceramic. And as you know from the previous lectures, a class 2 ceramic is a high lucite ceramic. This was a product called Empress, right? And it was a CAD/CAM restoration she had made. And so to cut through the Empress, it was really easy with a diamond burr. My preference when cutting through ceramic material is a diamond burr. Even if it's zirconia, which is also a ceramic, right? Zirconia is a ceramic. It's not a glass ceramic. It's a densely sintered polycrystalline, class 4 or class 5 ceramic. But to cut through zirconia, you really have two choices. You can either go the wild west technique, which is lots of water and a very coarse burr, but get ready for shrapnel to come out. Be ready for particles of ceramic to fly around the room and for the burrs to sometimes break off suddenly. And so those are just things you have to be prepared for. And when you look at American dentists, and I think also Canada, if you look at the way that we approach the removal of zirconia and lithium disilicate, you have the camp that wants to do things carefully and methodically with a fine diamond, something with a red stripe. And then you have the other camp that say, nope, not going to work for me. Give me the coarsest burr I've got and let me just hammer right through it. Both techniques work incredibly well. It's just a different experience, okay, for the dentist. One is going to be kind of things flying and breaking and chipping and even sparks coming off of the surface, and the potential for the burrs to be breaking midway through. And the other experience is more of a gentle, quiet experience. It's something done with a fine diamond and just very careful and slow. You melt away the zirconia. And I use the same technique for both zirconia and for Emax, and that is I use the fine diamond technique. I just found it to be less of a kind of a shocking experience when you're using the coarse diamonds. And I think either one works fine. Here I'm using a medium grit diamond to cut through this material because it's very soft. This is a material that's a lot like feldspathic. It was cutting through this was like cutting through Denton. It was easy. And so what I'm doing is using a 2 millimeter long diamond called a 330 diamond and putting it to the full depth as I go across. And now I have a stripe on here that I can use to determine the depth for my final preparation. And I'm just going to go ahead and carry that stripe mesial distally too, because now I've got a lot of really good information that I will now be able to utilize when it comes to the preparation and not having to worry about being too thin on my reduction. Okay. And so once that's done, I'm going to go ahead and do the reduction on the lingual side. And we'll do the reduction on the facial side. We'll do the functional cusp bevel, and then we'll place a little bit more bulk on that area with a little bit of a fillet margin. And then we'll block out the tooth where we have areas where it's a little thick. I like to do this. I just think that more of a uniform thickness in the axial and the occlusal areas, that it all contributes to a more accurate pressed restoration. This is going to be Emax. It's going to be fabricated through pressing, not through milling. And if we have everything uniform, the wax pattern is going to be more uniform. It's going to be more uniform in thickness. It's going to be smoother. And when you invest it and you burn out the wax and you press in the ceramic, we presumably will have a more accurate final result. Uniformity of wax is really key to having well-fitting restorations that are made through a lost wax process like gold or Emax that's pressed. Okay, so now we're ready for the adhesive delivery. And, and we need to kind of think about what's happening here. And, it's really a sandwich, isn't it? Where you have the ceramic on one end and you have the tooth on the other end, and then you got all this stuff happening in between. And I will actually spend time with patients and tell them all these steps sometimes, because sometimes patients need to be reminded of just how special we are as dentists. We are an incredibly special, smart, talented group of healthcare providers. And all of the materials we use is so complex. And you really have to understand chemistry and physics and biology to truly put it all together. And I'll oftentimes tell the patients, hey, it's like a really complex sandwich from the ceramic to the tooth, and everything has to be done exactly in the right sequence, in the right amount of timing, the right amount of material, and everything has to be dialed in just right so we can make that perfect sandwich. So let's go through this in a little bit more detail. Let's start with the hydrofluoric acid, okay? And so the hydrofluoric acid etch that is available today is all over the map. I mean, you can get the Ultranand or the Bisco at 9 or 9.5. You can also get weaker hydrofluoric acids that are even less. But when it comes to Emax, we're going to look at, it doesn't matter which one you use, which is very interesting. 20 seconds seems to be the magic number. If you go to more than 30 seconds, I think you could probably be fine up to 30 seconds. I don't think there's any study that shows 25 seconds is worse than 20. Most of the time they're looking at 10 seconds, 20 seconds, 30 seconds, or a minute. But if you go too long with Emax, you can over etch the surface. And then when you over etch the surface, those small little particles of Emax can kind of pluck out. So when you look on the right-hand side, and this is a milled surface on the left, and then in the middle is feldspathic porcelain. Feldspathic porcelain needs a longer etch because the particles, the filler particles inside are very large, and they go deep into the ceramic, where Emax is more like little small shavings, and each one of these little small Emax little crystals is about a micron or 2 microns in length, and they're very skinny, and you can over etch. And then what happens is all these particles flake off the surface. So you have to be really careful about over etching Emax. So 20 seconds seems to be kind of the magic number when it comes to using Emax. I'd also like to say this is a perfect time to talk about preventing stain margins. And when you have veneers, these are beautiful veneers, there's no doubt about it. I mean, they look incredible. They have beautiful translucency and the opacity and what have you. But if the patient had these veneers in their mouth for about 5 or 6 years and they came back and this is what they look like, they may have reason to complain. And you look at some of the irregularities around those margins and you think, well, what could we have done to prevent that from happening? Is there anything that could have been possible to prevent that? And so I'm going to suggest to you a few things, and they have to do with etching. And that's why I'm talking about it now, is how do we make this work a little bit better? Well, first of all, we can make sure that we can, whenever possible, put your margins on enamel. That's going to be a huge bonus in terms of preventing staining. Now, it's not always possible. And so sometimes we have to bury the margins a little bit subgingival, maybe a 0.5 millimeter to be safe. That can also help mitigate the visibility of staining. You need to have an excellent fit. You have to prep it perfect. You have to do perfect impression. And you have to have the perfect lab, right? And the word perfect is probably too strong of a word. Let's put it this way. You need to do a really nice, fine preparation, and you need to capture that with a proper impression or scanning technique by managing moisture and the soft tissues. And then you're going to have a lab that has an opportunity to give you the best fit possible. You have to use a really great cement. Don't shortchange yourself with any bargain brand cements. Go for the best that you can find. Seed it fully. It's surprisingly common for dentists to not get crowns cemented perfectly. It's surprisingly common. And and if you've ever had a crown you've tried in, and the patient says, gosh, that feels perfect, doctor, and then you cement it and they go, oh, it feels a little high, you just experienced a non-fully cemented crown. And what happened there was something didn't get down all the way. Maybe the extra cement inside of the crown created enough pressure, it didn't get down, or you didn't push fully. These kinds of problems happen a lot. And so much so that we're actually replacing crowns all the time with open margins. And those open margins were caused not because of an error in the preparation or the impression or the lab, but because they weren't seated properly. And then we want to utilize something called bull nose etching. Bull nose etching. So what I want to show you here in this technique is, you know, in the left-hand side of the screen, right, you see your typical laboratory will etch your ceramic on the inside. So that red area there is your ceramic etch. And then when you, as a dentist, and you go to etch the tooth, you etch beyond the margin, of course, and you end up getting a pattern that creates a little meniscus in time that will fill with stain. And so what happens here is you don't have a continuity of contour as you're going from ceramic to tooth. Now, you have to imagine these are high magnification, right? But if you do what we call this bullnose etching, you wrap the acid etch around the outer surface of the ceramic, about 1 millimeter. And when you etch around the outer surface of the ceramic and you etch the tooth, now you can get what we call a continuous ceramic cement tooth continuum, or seal. So you get this continuous seal. So I never let my labs etch my restorations. I always etch and silinate them myself, because I am going to make sure I etch around the edge. Okay. So when you grab your restoration, and this is in that MOD onlay that we were starting with, now we're kind of taking it to the conclusion. We're going to grab it with a stick, and then I like to use 5% hydrofluoric acid. And the studies have shown that the etch pattern of 5% is amazing. It's a great etch pattern, and I think that this would be a technique that I would utilize moving forward. I think I have a slide in here showing you a beautiful study that looked at the different etch percentages and found the 5% etch made by Ivoclar provided us with the best etch pattern and the highest bond strengths. So kind of interesting. But anyway, what we do is go ahead and etch around the periphery like this. If you have Emax that has a glaze on it, and most Emax has a glaze on it, you want to just put it around the edge all the way around like this, and realize that you may have to etch that outer area longer than you etch the inner area. If you don't have a glazed Emax, you can just put it on like this, and then fill the entire middle part. Okay. So right now what I'm doing is I'm doing a quick etch around the outside, and then applying the etch on the inside. Probably not the best photo, because I'm doing this live with the patient. And so what you'd like to do is try to put this next layer just on the inside itself. If a little bit gets beyond on the outside, I don't think it's going to be a big issue, because the outside has glaze, and glaze is feldspathic, and feldspathic needs to be etched more anyway. It's kind of almost impossible to over etch feldspathic porcelain. So remember, the glaze on the outside surface of Emax is not lithium disilicate, it is feldspathic porcelain, and that requires a longer etching time. So if you have that glaze on the outside, you want to etch the outer surface for probably closer to a minute, and the inner surface for, as we mentioned, 20 seconds, maybe up to 30 seconds, and then rinse again. And then you'll have a surface like this. You don't want to see the surface with white chalky areas that are standing in the middle of a nice matte finish like this. So this nice sort of like mist of opacity is what you want to see. And this will actually go around the edge of the ceramic as well. And then you're ready to move on to the next step, which would be silination. Most silane bottles that are sold in the United States anyway are single bottle silane. It's very popular. Ultradent makes a single bottle, Bisco makes a single bottle. And the problem with this molecule is that it needs to be activated. In other words, you need to take those methyl groups and you need to kick off that methoxy group and replace it with an OH group, with a hydroxyl group. So the only way to do that is with acid. Okay. So what the one bottle silanes do is they add acid to the bottle and it gets mixed together, and then it forms the hydroxyl version of that molecule. And those hydrolyzed molecules, unfortunately, are very reactive. And what they will do is they'll react with each other and they'll form these polysilanes. In other words, these large oligomers, that are going to be almost working like a separating agent. They don't have the capability of forming this beautiful silane to ceramic interface. So the one bottle silanes are okay. All right. I'm not saying you should just never use them, but you got to use them when they're fresh, and you've got to keep them refrigerated. Okay. But you have to warm them up to room temperature before you use them. So this is kind of a little bit of a problem, right? Because you put them in the fridge overnight, and then in the morning you have to take them out, let them warm up. And that may take a half an hour, 45 minutes, or an hour, or something like that. So your staff is going to be really on top of their game. And also, a lot of people will use their silane agents much longer than they should. And so plenty of studies have shown that if you use one bottle of silanes and they're near their expiration date, you're going to have reduced bond strengths than if you never use them at all. Isn't that interesting? So one bottle of silanes can be a problem. That's why I think it's worthwhile to kick it up to the next level, and that's to use a 2-bottle silane. Now, 2-bottle silanes, in one side, you've got the methyl groups attached to the oxygen molecule atoms on top of the silicon atom. And then in the other bottle is acetic acid. And so what you do is you add the 2 drops together, you mix it up, and you're performing chemistry right there in your office. You're activating all of those groups. You're displacing this is a substitution reaction in chemistry, where you kick off one group and you replace it with hydrogen, and now you've activated this area. And so the mixing of this 2-bottle silane there chair side just before you're ready to apply it to the ceramic is highly recommended. And the silane bond that you get it has no peer. It is absolutely going to be the highest bond you can imagine. So what you've got is this little molecule like this, and with the acetic acid, you replace those methyl groups with hydrogen groups, and you basically these are hydroxyl groups, and those hydroxyl groups are then going to bond to the ceramic interface here on the bottom, and then they're all going to connect with covalent bonds like this. And then on the other side, you're going to have all of these alkane groups or alkene groups that are going to then attach to the composite surface like this. So you kind of have this water-loving surface that's going to attach to the ceramic on the bottom, and then you have this hydrophobic side it's more like an oil, and that's going to attach to the composite on the other side. So it's a bipolar molecule. And one of the things you want to make sure you do is don't add multiple layers of silane over the interface of the ceramic. You want to just do one layer, and that's it. So you're like, well, wait a second. Here, I'm going to mix it up in the little mixing area, and I'm going to apply it to the surface. I feel like I want to keep applying it. And that is not a good idea. You want to just apply it once in one thin layer, and then I put it inside of my composite warmer for 5 minutes. And that's it. You're good to go at that point. 5 minutes later, that silane surface is going to be the best you could possibly do. This is at the top of the pyramid in terms of bond strength capability. We're doing a 2-bottle silane. We're going to be mixing it. We're going to apply it to the surface after 5 minutes of mixing. You just mix it up and just let it sit there for 5 minutes, then apply it to the surface, and then put it in the warmer, which is going to drive the reaction even further to completion, and never put a second coat on there. Never put a second coat of silane on the surface. Then what you're doing you're doing like the same thing you would do with a bad bottle of one bottle silane. You're creating a kind of a slip zone where all these molecules now are being sliding past each other rather than just serving as these little appendages that can attach to the ceramic that is going to go on the cement, which is going to go onto the silanated ceramic surface. One really cool thing about a silanated surface is that the silane is robust. It's not going to wear off. You can try in the restoration after silanating it, and if it gets contaminated with saliva, you can use IvoClean and just scrub the surface of the restoration, and you will not remove the silane. Isn't that weird? I mean, you would think like, oh, that little molecule is going to come off really easily, and the answer is no, it doesn't. The only way to remove the silane from the surface is to hit it with high strength hydrofluoric acid. That'll remove it. Or sandblast it, which is a big no-no for Emax anyway. Or the other way is to grind it off. So if you think your restoration needs to be adjusted, like maybe you're going to grind on the restoration, you don't want to silanate it until you're finished doing your alterations on the surface. But generally, and I recommend that if you're going to adjust anything, you should adjust the tooth. I've got my patient anesthetized, I got the rubber dam on, and if I have an area that's not seating down all the way, I usually will make adjustments on the tooth preparation away from the margins. Of course, I'll try that first before I decide to start grinding on the restoration. We don't want to make the restoration any thinner, so it really helps to do it the way that I've described. This is really for extraoral use only. It's a very caustic material. It's this very nasty alkaline product with a suspension of zirconium oxide, and I would not recommend that this ever be used in the mouth itself for cleaning off preps. This is strictly for extraoral use. So this is a really ugly temporary, but it did the job, and the patient came back. I basically just took a blob of Telio or Fermit and just plopped it on top of the tooth and shaped it and locked it in, and then said, I'll see you in a week, and then that's that. So the tooth has already been immediate detent sealed. In other words, we've already gone through the immediate detent sealing, and before we took the impression, we had to clean up the margins with a burr. That's one of the important steps of IDS. And then we took the impression, and then we pumice the surface a little bit so that nothing would stick to the surface in the temporary phase. And then after that, we're ready to go with the removing the temporary. When she comes in for the delivery visit, we'll remove the temporary. And then I like to sandblast the surface. You can also use, like a piezo or ultrasonic to remove any residual cement, and then sandblast the surface, do a total etch technique. And now I've got such a great hybrid layer that I established with the Optibond FL that a lot of it's still there, but I still want to get a fresh etch and a fresh bond on top of it. And now I'm going to switch to the technique that I prefer, which is to use an 8th generation. So you need to sort of divide immediate detent sealing and delivery into two different camps. One is being done to reduce post-op sensitivity and improve the quality of the hybrid layer, okay? Because you grab it before the dentin gets contaminated. And then the delivery phase, you think more about what is efficient and what method you would rather use to get a completely cured interface. And so I'm going to show you that in a moment. So go ahead and rinse really, really thoroughly, and then suction it to a moist consistency. So it's kind of like the sand after the wave ebbs and pulls back out of the way. And then we're going to do a 60-second times 2. I like 120 seconds. So scrub with the chlorhexidine after you've etched the surface, and this is going to kill any bacteria that might be laying around, but also it helps to mitigate your matrix metalloproteinase activity, so you can knock down the MMP activity. Even if it's only for a short term, at least is going to give you an initial good bond. And so we really like using this 2% cavity cleanser. And then I'm going to go ahead and use my universal adhesive. And you're like, well, wait a second. I thought you use Optibond. I go, yeah, I use Optibond for the immediate dentin sealing because it's a filled adhesive and it's really robust, and it's the original technique Monnier developed. But when I go to cement, Optibond FL is not my bonding agent of choice because it doesn't have this connection with the cement in the way that the Universal does, this Scotch Bond Universal. Because what the Scotch Bond Universal does is it mixes with the Reliax Ultimate cement made by 3M, and they are designed to work together and polymerize themselves. So there is an activator in the Reliax Ultimate cement on the right-hand side, right there in the middle, that green one, that will activate the Scotch Bond Universal. And so they work as a team. And so I don't have to light cure the bonding agent before I cement the restoration. I can apply the cement to the restoration, insert it on the uncured Scotch Bond Universal, and then I'm going to deliver my restoration that way. There are other ways of doing this with Dual Link and Panavia, and other companies have their own version of this. But basically, you want to find a bonding agent cement combo that works together to cure itself. Does that make sense? You want to make it so that it'll cure itself. Now, if you don't do that, if you use, like some people use warm composite or to cement their restorations, which does not have the chemistry inside of it to activate the Scotch Bond Universal. It doesn't have that in there. You're relying on your light cure unit to go through the restoration and get all the way down to that layer below the cement. Is that possible? Absolutely. Does it happen 100%? No, but it actually can work quite well if your restoration is translucent. If your restoration is not translucent or is very thick, I would recommend against using the warm composite technique, or against the idea of trying to get everything activated with the light, with a cement that may not have the chemistry to force that force that Scotch Bond Universal to polymerize. Does that make sense? So think of it this way: you want to get a pair that works together, and the Reliax Ultimate, the 3M product, works beautifully with the Scotch Bond 3M product, Universal, because the Reliax Ultimate has an activator inside of the cement itself that will polymerize that 8th generation Universal adhesive that they make. So that's pretty sweet. You have this combo. For veneers, we're going to be using the products on the left, and that's going to be coming up in our next seminar. We're going to delve into veneers. But we use light cure cements for veneers. We like to use dual cure cements for all the posterior restorations because they will cure quite nicely, even in thick restorations. So I like to put a little bit of adhesive on the inside of the silanated restoration because it will help with wetting. It allows the cement to flow really well. But you need to evaporate the solvent. This is critical. You cannot just slop it on there and have it all wet and then put in the cement. You must let the solvent evaporate. Otherwise, you're going to experience decreased bond strengths. So now we apply the cement and in it goes. And so when it gets placed in a position, we're gonna really push hard on this. And so you see here, I'm using kind of like an acorn burnisher, and I'm pushing about as hard as I can. I am not allowing this to just float in there gently. I'm not going to just have a patient bite down on a cotton roll or something like that. That is not going to cut it. You got to get this cemented down completely 100%. And if you have tight contacts and you try to deliver this, you may not get it down all the way. This is a fussy technique. Onlays are much more difficult to get perfect seal everywhere because there's so many vertical walls and there's so many retention areas and there's so much that can go wrong with an onlay. To get them to really seat beautifully takes a significant effort on the part of the operator. Now, what I'm going to do now is something that may be different from what you all are doing, and that is I am not going to tack cure. I am not going to tack cure. I'm completely against the whole tack cure process, and I'll explain to you why. I like to go ahead and light cure for about 5 seconds or so to get an initial gel, and then I'm going to apply glycerin, and I'm going to light cure on all surfaces with this glycerin covering the margins to minimize the air inhibited sticky layer that may persist after you're done light curing. And I do this in 20-second increments. So I'm going from occlusal buccal to occlusal to lingual, buccal to occlusal to lingual, buccal to occlusal to lingual 3 times. And the entire time we're doing this, the assistant is blowing air spray to keep the tooth cool, so we don't have excessive irritation during this process. So not only am I using a bonding resin that is compatible and activated by the cement, I'm also using a dual cure cement, and I'm also light curing significantly the final restoration with air coolant. Without the air coolant, post-op sensitivity issues are common. Now, let's take a look at the interface. This interface, and this is blown up mega, right? So I made this little drawing, and you have back on the upper left, etched enamel on the bottom. And I drew this to scale. So this is a 500 micron zone of etched ceramic. You know, we talked about that bullnose etching that goes around the corner. And then you may have a 75 micron gap with your inlays and onlays. That's really common. We have that kind of a gap all the time. It's perfectly normal. What we don't want is we don't want a 0.5 millimeter gap. Now that's just asking too much of the cement, but a little gap is normal. And so you have your resin here. Now, if you're going to do the tack cure technique and you cure this for 5 seconds or 10 seconds, and then you come in with your Explorer, and this is the real size of an Explorer. This is a pointed Explorer that you could poke you right in your finger and you could get a drop of blood, right? I mean, this is a sharp Explorer, but that's what Explorer looks like under the microscope. So if we go to that interface with that Explorer and we lift up on this margin and we try to remove the cement, there's a very high likelihood that it will rip away because it's not strong enough yet. It's at the gel state. And so when you rip it off like this, you leave behind a gap. Now, it may be sealed internally, but externally, we end up having a disruption of that interface, okay? This is an example of tack curing results. Look at those ripped out areas in this study that was done by Wells, looking at tack curing, and you look at the interface here between a veneer and a tooth structure. It's pretty obvious what happens when you tack cure and you remove the cement. You get it ripping away from the interface like this. And so stained margins with tack curing are very, very common. I have not tack cured for almost 2 decades. I think when I heard about tack curing, I thought, wait a minute, that doesn't sound right, because you're ripping the cement away from the interface before it's actually at its final state. That would be as silly as somebody telling you, oh, why don't you tack cure your class 5 composite and then finish it and polish it and then do the final curing later? That would be ridiculous. Nobody would do it that way. We all smooth the surface of a class 5 as best we can, and then we do full curing, and then we finish and polish it. I mean, why do we change the topic when it comes to, why do we change our approach when it comes to onlays? I think it's because we're just really afraid of excess cement. And if you don't have to be afraid, I think just remove it and you're going to be in better shape. So I like to prefer the clean and cure technique. Rather than tack curing, we do the CNC technique. And what that means is you reduce the volume of cement by just smoothing it as best you can. And then you apply your glycerin, you light cure through, and then we have a stain resistant continuity between ceramic, cement, and tooth structure. Here's an example of what happens when you do a non-tack curing approach on ceramic veneers. And look at those scanning electron micrographs on the right-hand side. The upper one and then the lower one. You say, oh, wait a second, Dr. Stevenson, that's a huge marginal gap. But if you, that's not a gap, that's the tissue. And then you have to look to your left a little bit, and that is what we call the continuous ceramic seal that you can achieve by doing the bullnose etching, right? Combined with the non-tack curing approach. And these are veneers 10 years later, flawless, beautiful finish lines, beautiful margins, no staining whatsoever. This is the non-tack cure bullnose etching approach. And in a beautiful study that was done by this group down in Brazil. And I just think if we want to bring our dentistry up to the next level, we need to think along these lines. And then I'm going to utilize a 30 micron diamond to finesse the margins at low RPM, 10,000 RPM, with copious amounts of water, and go through the polishing sequence, utilizing whether you're using the feldspathic polishers like I'm doing here, or the Emax polishers. They both work almost exactly the same. The difference is that the Emax polishers use 2 steps and the feldspathic polishers use 3 steps and take a little bit longer to get the job done, but they both can work quite nicely. And then you rotate always from ceramic to tooth with plenty of moisture, so you're not going to be running the abrasive in the direction against the margin. You're going to be in a direction of smoothing it, much in the same way that you would finish down a gold casting or even a composite. And this is the kind of interface that we get, and this is the kind of interface that I would expect to see on this restoration for many, many years without problems. So I'm going to summarize tonight with just 2 slides, and this is going to give you exactly the approach I would take for the IDS step at the preparation and the delivery. I need to change the word here so it's very clear. I'm so sorry. There we go. Preparation. I did it. That's cool. Okay. 1 second, everybody. I need to save it, but I can't because the icon's in the way. There we go. Okay. We'll go back to that again. So here we go. So preparation, the steps are as follows. After you finish prepping your restoration, you're going to go ahead and do a total etch technique, and you're going to then rinse. And immediately after etching, you always want to use a 2% chlorhexidine, and I prefer using it for 2 60-second scrubs. So for 2 minutes, okay? And then you're going to suction that off so that it's somewhat moist. And then at this point, you can use your Optivon FL primer for 20 seconds, really scrub it in there, and then air thin for 3 seconds. And then you're going to use the Optimon FL adhesive for 20 seconds, air thin for 3 seconds. And then I want you to wait for about 60 seconds. This is something that the biomimetic groups have determined that you really need to wait for the hybrid layer to fully intermix and to reach its maximum penetration into the dentin before you cure it. Don't cure it too soon. Just let it kind of soak in and mature just a little bit. At this point, you can cure for 5 seconds and then cover it with glycerin and then cure another 15 seconds. And you say, well, why don't you just cure it for 20 seconds? Why do you need the glycerin? Well, the glycerin is going to minimize the air-inhibited layer. We want to cut down on the air-inhibited layer so that we don't have our temporary sticking to the surface and making it impossible to remove the temporary. Now, here's the catch. After you light cure, you have to refine the enamel margins. So even though you've already covered all the enamel and everything else, your margin is no longer as crisp and well-defined as it was, right? So the margin, unfortunately, is a little bit filled with some of the adhesive and it's kind of irregular. And so you want to take your fillet diamond and go around the periphery and clean up the enamel one more time. And then once you've done that, you can pumice the preparation. You can take your impression, right? Then you can pumice the prep again if you want to make sure you don't have any residual air-inhibited layer that would stick to your temporary. Make your temporary and cement it with Duralon, and then you're good to go. Your patient is going to have a pain-free experience with your temporary. They're not going to complain at all. I've even had patients have the temporary fall off, and the patients have said, oh, the tooth is totally fine. It's so comfortable. And without the temporary, I brush it and rinse and everything. I'm like, oh my gosh, this immediate dent and sealing is incredible. You know, it really does things that we cannot do other ways, right? At the delivery phase, and this is the onlay that is for that preparation I just showed you, we want to remove the temporary. Now, as long as you have used glycerin and you've pumice the surface, you're not going to have your temporary stick and bond to the air inhibited layer. So that's really going to work out quite well. I do air abrade with 50 micron aluminum oxide. I etch the entire prep for 15 seconds, then I rinse for 20 seconds. It's a long rinse. We want to make sure everything is completely out of there. All the acid is out of all the little areas of the onlays, all those little box areas and things like that. And then we're going to do our chlorhexidine for 2 minutes, suction moist, and then apply our adhesive. And for me, this is where I use a Scotch Bond Universal. Then my cement will be Reliax Universal Ultimate Cement, and the two of them work together. I'm going to seat it. I'm going to clean it. I'll light cure for 5 seconds, cover with glycerin, and then light cure for 20-20-20, 20-20-20. And I think if you perform all these steps at preparation and cementation, there's 25 steps. If you do all of these things, you're going to see that your results will be consistent. You're not going to have post-op sensitivity, and you're going to hopefully have margins that don't stain over the course of time. When we go to our next segment at our next meeting, we're going to start to get into other techniques of cementation and how to deal with zirconia. Not only taking off zirconia, but also taking off Emax, how we would approach that, and the cementation of Emax and zirconia full restorations. How do we handle those? Are we going to bond them? Are we not going to bond them? And if we are going to bond them, when do we want to bond them? And how to then make the final occlusal adjustments on the crowns and get the best polish possible so the restorations will last, hopefully, many decades. And so I think because it's 8 o'clock, we'll stop there. I'm happy to do another 5 minutes of Q&A if that's okay with people. And then for those of you listening to this as a recording, there will be a quiz. For those of you who are here, you don't need a quiz, you get your credit. And Stevenson Dental Solutions will send you all the credit for the 2 hours tonight that you spent with us. And Univet will provide us with a complete list of all the people that were here tonight. So we have 2 more sessions to go. And our next session will be determined soon, but it'll be again on a Thursday night at 6 p.m. to 8 p.m. Pacific time. And with that, I'll hand it back over to our moderator.
Thank you, Dr. Stevenson, and everyone. That was awesome. A couple questions here. I think you might have answered them, but do you use air particle abrasion prior to etching?
Do I use air particle abrasion prior to etching? Absolutely. Yes.
How do you feel about Ivoclar monobond etching prime?
I love Ivoclar as a company, and I really appreciate a lot of their products. The only problem with that approach is that we don't get the kind of etch pattern on the Emax you can get with a 5% hydrofluoric acid. It's just not the same. So when you look at those etched patterns, they're the study that was done out of Brazil looking at that and testing the interface found that was the weakest bond of all etching options you had available to you. But I have to tell you that by having everything in one bottle, it can simplify things and maybe reduce errors that you could have by having silane as a separate step from the etching. But by combining them into one bottle, it may simplify things. I know one of my colleagues, Leanne Brady, who does a lot of lecturing around the country, quite an accomplished clinician and teacher, she swears by it. But I'm a little confused because the studies that I've looked at have shown that it's not quite as good of an etch pattern, and the bond strength is a little bit lower than some of the other combinations, particularly the combination that I was describing for you this evening. But I mean, if it's working well for you and you're not getting debonding and you're not getting sensitivity and you're not getting stained of the edge of the margins, then I think it's probably worth continuing to use.
Okay. Another comment here. Apologize if I'm pronouncing this incorrectly. Dr. Vinod, thank you so much for enlightening us with your vast experience and expertise. Here's another question. How do you remove excess cement material in the proximal area?
Yeah, great question. A lot of times, and I think you might have seen it in that one slide where I showed the light cure unit going 20-20-20. I like to place dental floss interproximally in cases where I think I'm going to have difficult access to removing cement. And remember, I do a lot of cleaning before, right? So I really get the floss between the teeth a lot. I use a rubber tip to remove a lot of excess, those little gum rubber tips. I get a micro brush. I mean, I work really, really hard at getting everything super, super clean before we cure. And then that's reduced my pain dramatically. And then as a backup though, sometimes you need to remove excess, and that's where we're going to utilize, our 15 blade, not our 15, but our 12 blade curved scalpel blade to remove excess. And then, I'll even use chisels, like a Wiedelstadt chisel or enamel hatchet can sometimes be used to remove excess. But I will tell you, never, with a capital N, never use a rotary instrument on the dentin ceramic interface when removing excess cement. I have to do it with an instrument so I don't gouge into the dentin and cause problems.
Okay. Cindy, we got another link for you, so check out that one and let us know if that works. I think that's it. Gosh, Dr. Stevenson, I'm out here on the East Coast, and
awesome.
All the East Coasters for sticking through tonight. I'm tired, man. It's 11 o'clock over here.
I hear you. Thanks so much, Devin. Thank you, everyone, for sticking with this course and listening and allowing me the opportunity to share the science and my experience with you. It's a joy. I hope that I get to meet some of you or re-meet you if I already have met you. I'm in Chicago every year at probably the best dental meeting on the planet, which is the Academy of Operative Dentistry meeting. It's mind-blowingly good. This is where the experts go to get the latest information. So if you want to go to the meeting that all of the speakers go to before they speak to the world of dentistry, that's the meeting to go to. And I would love to meet you there and see you. It's well worth every penny that they charge, and it's not that much. So check that out. And I look forward to seeing everybody next time. And we'll get that date worked out, Devin and Carla, and let everybody know, but it should be probably in about a month or so. We're spreading these out about a month. Okay, fantastic. And you'll let everybody know.
And everyone, and to everyone out there, you're getting our communication on when the webinars are. I think it goes without saying that Dr. Stevenson is a great resource. Everyone's sticking around. I think the list of participants is growing, so thank you. Please continue to share these webinar series with your peers. Check Dr. Stevenson and us out on Instagram and YouTube. Go to his website. And thank you to everyone that sent me messages to check out our loops. I really appreciate it.
Thank you all. Have a great evening, everyone. Take care. Bye, everybody. It was a pleasure.
Thank you.
Take care. Okay, thank you.